So I think now we move on to the actual clinical scenario, and there's no better person than Abhijeet to discuss some clinical scenarios with us. Abhijeet?
Yeah, thank you, sir. Thank you, Alcon. Thank you, AIOC, for having me here. So what we need to do is we need to understand the needs and expectations of the patient. And at the same time, we are also setting the expectations. So there's going to be an overlap with Dr. Bhaumik. So the potential candidate is who is having multiple activities at different distances, wants spectacle independence, has a positive demeanor, usually qualify for bilateral implants, no previous refractive surgery, especially when you're a beginner with presbyopic correcting IOLs, and understands technology versus God-given. So that is something that I actually put into their head when they come to me. May not be ideal are the patients who enjoy wearing glasses and not opposed to wearing glasses, impatient or type A personalities, pre-existing eye pathologies, and all those things that Dr. Arup Bhaumik has already talked about. But I would add to it poor endothelial cell counts, especially guttate changes, irregular cylinder, and dry eyes. Yeah, definitely. We do have a lifestyle questionnaire in our OPD, and we try to find out patients who are on antidepressants or antipsychotics, which would be a clear no-no. I especially take inputs from my staff, the optoms, as the personalities who are hard to please. And these kind of personalities actually affect the adaptation, the neuroadaptability that happens over a period of time. It's a rough flowchart that we follow, but essentially counseling is the key, and we need to understand the needs and expectations, and we need to understand what activity the patient values the most. We aim for plano. The present wear progressive makes it easier for us to counsel. If the person is on progressive, definitely understands the technology. And we talk about work or play as well. So with the newer generation of corporate people coming up, there are a lot of people who are working, playing cards and other things. So we need to look into that as well. So we explain all possible outcomes. We have a chair time, but that's with the optoms. I don't spend the chair time with the counseling. We explain technology, not the cost. We promise the patients that they will not require glasses for 99% activities and may require a minor spectacle power occasionally. And we always take an informed consent once they have chosen the lens that they have been given. And we also talk about, we instill confidence in the lens. So rather than talking about halos and glare or rave about them, we set realistic expectations for the patient that this is what you're going to get, and this is the light that you're going to be working about. So we need to know whether how many times are you going to be in pitch dark, or you're going to be driving on pitch dark roads in the rural areas, not on highways. So we talk about halos, but don't rave about them, and we underplay them. And we always tell them that most of you also will see, and if you accept it, only then go ahead with the multifocals. And we have valuable educational resources for them. So we always underpromise and overdeliver. We have a extremely diligent pre-op workup, which includes dry eye workup. We preferably do a topography for all our patients. And we do, I operate on the Varion, so definitely a planning station would be good, but there's no harm in using the Barrett online toric calculator, and always use the toric calculator so that you correct the astigmatism, however low it may be. So, and that trade-off is worth the trouble, because that astigmatism is the one which gives you the wow factor. So the acid test is to check the company claims and actually use them. So I have put up the scenarios in which I have used the patient. The photographs are not of the actual patients. So we have a 40-year-old bilateral PSC, a software professional. The right eye was operated for restore with plus 2.5, and he was extremely unhappy because for some reason he was not even able to see the computer very clearly with the plus 2.5. And he had halos and glare. Near vision also, he was not very happy. Not very happy with intermediate. He came after 2 years for the left eye surgery with a mature cataract. Fortunately, we usually do a bilateral biometry. So we had biometry readings for his other eye also. So he was ready for a +3, in fact. But at that time, I had just started using Panoptics and I was very confident about it. And we was counseled for Panoptics. And this was his reaction on the day 1 of surgery, because he had not seen that well for ages, and he could exactly see the shade of the brand new car, and he was very happy with his near and intermediate work right from day 1. This is the second case scenario, a moderate myopia, which I would actually be very hesitant to advise multifocals. So nuclear sclerosis, PSC, and he had glare and halo as a complaint with the cataract. Very demanding, and was explained and counseled about Panoptics, and was operated on both eyes 1 week apart. And he's, even after a 6-month follow-up, extremely satisfied, and he happily drives at night as well. But that's urban driving. This is a 50-year-old guy.
Hello, Abhijeet.
Yeah.
Let's put a hold for a little bit of comments on the case that you described.
Sure. Yeah.
Arup, Michael, do you have any other comments? Would you have managed a little differently, or any other thing that you want to bring it out from the two cases that Abhijeet described just now?
Look, I think the first case is a 40-year-old patient, and he's got plenty of accommodation, and that's why he wasn't happy with the Restore 2.5. It's just not going to give good enough near and even intermediate compared to a 40-year-old with accommodation. And you hit the nail by giving him a Panoptics, and he was coming from a bad place. His lens was white, and so he had a phenomenal improvement, and he got the near vision you get with a Panoptics. So I think that was a great case to demonstrate how well it can do. And a 40-year-old is very different to a 60-year-old in terms of their expectations of their vision. Your second case, I wasn't sure what you meant by moderate myope. I still worry about a trifocal in a -2, -3 patient. In a -5 or a -6 or a -7 or a -10, I have no problem. I think they do great. But I think the -3s, I still get a little twitchy about.
Yeah, so he was wearing a 1 eye -2 and a 1 eye -3.
Wow, yeah.
So that's something. Why you worry, Michael, with the Panoptics?
I think because they've spent their life with terrific -3 near vision at a really good working range. And it's hard to compete with that. I mean, Panoptics does it, but it's tricky for them to turn off their brain and say, okay, that's where I was and this is where I am now. You can get away with it, but I think that's one of the few type of patients where I get a little twitchy.
I think this is very important that Michael brought it out. Please keep in mind the refractive history and what they've done and how they were happy. And you can discuss that with patients if in doubt, but be careful in this myopia from -1 over up to -3 or so. So, Arup, do you have any comments on these cases?
I'm absolutely agreed with this, what Dr. Paul has told. This is a low myopia is the most dangerous patient. They become very difficult to satisfy with the multifocal lens, because they used to see the near vision without glass. And in high myopia, even in presbyopic age, I saw that used to have the presbyopic lenses, progressive lenses. So in high myopia, I find extremely good in cases of Panoptics can work very good, but low myopia should very careful to selecting patient. You have to explain everything, but in the same time, I never mind to select EDOF lens in cases of low myopia also.
Okay.
Panoptics vis-a-vis EDOF.
Yeah. Okay. Let's move on, Abhijeet.
Yeah. So this is a gynecologist who does laparoscopic surgery, plays golf, and he was counseled for Panoptics again, and he's extremely happy to be independent of glasses for his work as well. So seamless transition for different distances. That's what he has explained. He's described how he is seeing it, because these are the patients whom I can actually ask what they are experiencing.
So I think this is the case where golf will involve distance and intermediate, and also the laparoscopy. vision. This is a very good example where the patient is very satisfied with PanOptics, and knowing the function of PanOptics, it is quite expected that they will perform well on those activities. Any comments on these golfers and other these surgeons? Both of you, Michael and Arup, anything?
Well, I've operated on one ophthalmologist and put PanOptics in, and he was very happy, and I could talk to him as a colleague and as a friend, and he said the quality of the vision down the operating microscope was just normal. He had some halos around lights at night, but in terms of clearness of vision and being able to do his work as a microsurgeon, it was fine. He had no problem at all. So I think
that's interesting.
These focus are compatible with very good clear vision.
I think that the quality of distance vision is not compromised very much, and therefore through the microscopes and with that intermediate, they are happy as a surgeon, as a golfer, and so on. So I think PanOptics is changing and expanding our net for putting these lenses. Okay, go ahead, please, Abhijeet.
So this was a doctor's father, and he's an accounting and trekking both. And unfortunately, he had a faint corneal opacity in one eye and was operated with a acris of toric monofocal. So when he came for the other eye, we had asked him that whether do you want to opt for a PanOptics, and he was fine with it. And post-op, he was 20/20 and N6, but absolutely no issues adjusting binocularly, no halos or glare, and he's around 70, so he's very happy, no complaints.
Now, would you have put other multifocal before, if this patient was before the PanOptics era?
No, I wouldn't have.
No. Okay. Any comments? Arup, Michael?
So I never tried planning or PanOptics in one eye, other eye is a monofocal lens. But I saw this patient. I have did surgery PanOptics, and the patient was operated other place. And as I mentioned in my presentation, there's two kind of patient. One kind of base lens, and he even in that clinic they asked for the base lens. They implanted IQ lens. So after he came to me, and he was happy. He was happy. He was not complaining about anything. So he had a right eye has a IQ and left eye is a PanOptics. So, but I never tried the inocular PanOptics or planning for that.
I think you can get into trouble with a monofocal in one eye and a PanOptics in the other eye. If they focus on the clearness of the monofocal eye and feel that the quality is degraded in the PanOptics eye, and it's not quite as the same, there's a different quality of vision. If they focus on that and they're not warned about it, I think you can get into trouble. And maybe because of the corneal opacity in the monofocal eye here, so the clearness was perhaps degraded somewhat, so that it wasn't such an issue. But I think mixing and matching with a monofocal and a PanOptics, it can be a little difficult with some patients, I think.
I think that's where, if the surgeon is enthusiastic and patient understand, preoperative counseling and telling him not to compare each eye separately, because that's the common habit. Second eye they do and they compare, it's not as good as the first eye, and they look at the light bulbs and things which they never looked at earlier. So I think we need to educate them if they ask for it. I would not suggest PanOptics straight away, but if I find that a patient is wanting and he would welcome this less dependence on glasses, I would certainly consider it in the monofocal in one eye, having had the good counseling and selecting the right kind of person.
So would you opt for a EDOF instead of a PanOptics in such cases?
I don't have much experience of EDOF, I must say that. I'm looking forward for the new lens, which Michael is going to talk about, but I really have not had mixed match with EDOF and PanOptics. I'm a bit, I don't have enough experience, to be honest. Okay, let's go ahead. Next one. Abhijeet.
So this was a 31-year-old patient with a unilateral PSC and steroid-induced cataract, and was counseled and operated with panoptic toric and flax, again 6.6 and 6 for intermediate. But for my sake, I asked him whether he finds a difference in the vision between the two eyes, because it's a young guy. So this was one person who told me that I don't find any difference between the colors and the details. In fact, the operated eye is much better. So maybe I got off, maybe because that was the dominant eye and that was the non-dominant eye, maybe.
Yeah, that's as Michael brought it out. We expect them to find a difference, although they will be happy to accept that because they're motivated, with the advantage of panoptics. So, but if you ask them, maybe they would. But as long as they accept it and they're happy, that's what matters. So it seems that one eye phakic or monofocal, with the right selection of the patients and education, it is possible to consider panoptics, but you need to be cautious about it. Okay, let's move on.
So the main bane of the multifocals is the halos and glare. So in our practice, we explain everything. We show them the glare halos, but we prepare them mentally to face them and not be scared of them. So all are counseled that they are there, but they will not impede their judgment in any way. So even if you're seeing halos, you will be able to drive even if it's at night. And maybe if you're having
sorry to interrupt you, sir, but the time is up. So probably
this is my last slide.
In next 30 seconds. Sure.
Yeah. So we also tell them that the best way to lessen the glare and halos is to switch on the cabin light when you're driving, and the other way is to overlook them and underplay them. So this was a small study, but none of my patients actually really complain of halos once they have been counseled well. So unless you ask them, definitely they'll tell you that they do see him. To summarize, it gives a seamless near to intermediate vision, and we have significantly lesser complaints from patients with panoptics with relation to glare, halos, or intermediate vision. And it has become my go-to lens, especially with the 88% plus light transmission and lesser drop in contrast and better color saturation.